Good morning, everyone. My name is William Shi. I'm one of the PGI5 cardiology residents here at U of T at St. Michael's Hospital. Today, I have the pleasure of presenting our Christmas Echo Ho rounds. Um, it's going to be a case-based rounds. We'd like to present some interesting cases with hopefully some Christmas flavor to it. So please just sit back, relax, and enjoy. So we have patient number one here. This is an 81-year-old gentleman. He's referred to the structural clinic here at St. Michael's, as we are a structural site as well. So he has had a previous RV lead extraction for infected lead as a part of bacteremia. Uh, this was done elsewhere, and he was not dependent on the device at the time, and this was removed. Shortly after, he developed worsening shortness of breath with pulmonary edema, as well as NYHA class 3 symptoms. Uh, on examination, you could find bilateral pitting edema, crackles, and giant CV waves on exam. So we're going to take a look at some of the videos. Can you see the videos?
Yes, indeed.
Perfect. So we'll just play it a couple of times. This is the peristernal short axis of the RV inflow view, looking at the tricuspid valve. So it might be hard to see, but we can see a coaptation gap between the two leaflets. Also looking at the Doppler flow, there appears to be a large regurgitant jet coming through what looks to be the center of the coaptation gap, but maybe a bit eccentric. There's a large central jet, and partly there may be a central component to being the site as well. So essentially, I don't have the Doppler profile in this picture, but it's pointed towards moderate severe tricuspid regurgitation, and he was having NYHA class 3 symptoms with this. So, this one is not showing up. So, anyways, he was scheduled to undergo a minimally invasive tricuspid valve replacement, as he was not a candidate for TriClip at the time, and this was felt to be a better option for him. And he was not a surgical candidate due to his advanced age at the time, and the risk was felt to be quite high. So he underwent a tricuspid valve replacement. Transfemorally. This is something that St. Mike's offers as well. So I'm just going to show this clip. It's very short a couple of times. This is, again, the peristernal short axis view. Looking at the RV inflow, we can see this sort of bulky structure in the middle that appears to be a new valve that's been placed. Interestingly, this valve has a bit of a what we describe as a rocking or excessive mobility, and it's not as well seated as expected. So when we see this on, just our initial 2D view here, one thing that to consider is this valve going to be causing you problems? And one of the main worries is when it's rocking like this, is there dehiscence of the valve or partial dehiscence, which can cause some problems, as we'll see. So I don't know what the pictures are going to show. You give me a minute, maybe. Give me a moment.
No worries. Take your time because there's always one of the challenge of doing echo rounds with moving videos. Well, we now have 40 people online, so Thank
yeah, I think
you
it's
for joining today.
No pressure though.
now. There we go. So share my screen again.
Yep.
This works here. Can you see
Yep,
the
we
video
see it.
now?
Yep, we can see it very
Yeah.
well. Thank you.
So we're gonna replay that a couple of times. Here we have a side-by-side view. I believe this might. Oh, oh yeah. No, perfect. I'll put it on a loop so we can keep looking at it.
Yep.
There appears to be a paravalvular jet coming from the side of the valve that appears to be rocking. So look at the left side, there's a slight rocking motion of the valve. And on the right, there appears to be a moderately sized regurgitant jet that's a bit eccentric, which can make quantification of this jet and the degree of regurgitation quite difficult. But certainly, this is not what you would expect with a fresh valve that's been just placed in. And the patient himself was also having symptoms from heart failure as well that has not been improving. So, due to these findings, the structural team was informed, and we'll just go to our, see if we have any more. Again, some more pictures. Well, just so everyone can appreciate that full rocking motion of the valve. Same view we had. And so this is the Doppler profile. So it's the peak velocity here of the CW Doppler of the regurgitant jet is around 2 meters per second.
Yep.
But looking at the profile of the jet, it's quite triangular early peaking. So this is all suggestive of likely moderate to severe regurgitation. And the thought was this is most likely paravalvular because of the rocking motion of the valve, suggestive of partial dehiscence. So this is the conclusion that was reported in our study. We had an interval insertion of a bioprosthetic tricuspid valve. I've left out the name of the valve for confidentiality because it might be part of a study. But the bioprosthetic valve is canted and tilted posteriorly and displaced towards the right ventricle. We call it mildly excessive motion, but most importantly, there's moderate severe paravalvular regurgitation characterized by the triangular shaped Doppler profile. And quantification was not done due to the eccentricity of the jet. And when the structural team was noted, along with the patient's clinical features, ultimately he had to go back to the operating theater to replace this valve surgically now to completely fix this issue. And he did well. He was shortly discharged after this was completed. So this case is sort of to highlight the, which what we'll talk about here is the excessive motion in a rocking valve. This is something that we should assess routinely when we're looking at prosthetic valves, especially if they're fresh, or actually if they've been there for a while and patients are developing new symptoms of heart failure. And it's a sign of valve dehiscence. It can be seen with surgical valves more commonly. But the main issue, like I mentioned before, is that there can be a paravalvular regurgitation that leads to heart failure. Some patients may actually describe a sudden sense of like a snap in their chest. They can develop hemodynamic instability if the dehiscence is severe, even sudden death. And it can also be associated with infective endocarditis or abscess formation. And that ultimately leads to dehiscence of a valve that's priorly implanted. Looking at some of the guidelines at this issue, it's mentioned that the independent or rocking motion of a replacement valve is a sign of dehiscence. It may be more diagnostic for valves in the aortic position. Most of the case reports on this issue has looked at the aortic valve more commonly, where the rocking motion is more visible as well. And typically, and also on the left side is a higher gradient system. So you may be able to see a bit of a more rocking motion than you would see on the right side, which is the case here. And something you can do is also looking at the excessive ring motion, meaning how many degrees the rocking that you are looking at. And typically when you're just looking at a 2D view and there's more than 15 degrees, that's suggestive of a significant paravalvular leak. To note that in the mitral position, actually, there can be increased mobility of a valve due to the annular motion, atrial or annular reconstruction of the location of the ring. So sometimes you do see some mobility, but what you have to do is really look at the valve from different views to make sure that you're not missing a paravalvular leak. And if you do see that mobility may be actually suggestive of dehiscence. And also, as a part of this, you can consider alternative modalities such as cardiac CT, which can be quite effective to look at this. So just to move on for time's sake, this is case 2. We have a 54-year-old female. She's referred to heart failure, actually from the internal medicine ward service. This is a lady who came in with pulmonary edema, AKI bilateral pitting edema. She has some other issues going on, which I will not go into here, but essentially she had an ultrasound and echocardiogram. Of note, this is our initial ECG, just to put it out there for some people to look at. One notable feature is just the extremely low voltages across the precordial and limb leads, which makes you suspicious for something. It's a bit of a left axis deviation as well, but that's about it. So this is the loop. So this is our personal long axis view of the heart here. Just to start off, we can see a very hypertrophied LV. The left atrium appears to be dilated. There's a bit of a small or trace, probably trace here, pericardial effusion that you can see as well. The systolic function appears to be preserved, but we'll take a look at some of the other views here as well. This is the apical 4-chamber view of the heart. Again, a very hypertrophied ventricle. There's a bit of a trace pericardial effusion again. And one notable thing here is the spontaneous contracts or smoke that we see in the LV, suggestive of a possible low flow slate, as well as we see a very severely dilated bilateral, biatrial size. So the next pictures, this is just a zoom in view of the LV. Again, very hypertrophy ventricle, some spontaneous contrast that we see. This is the 3-chamber view. Oh. Again, similar to the things we've discussed before. So looking at these pictures, once we do the measurements here, we can see a significantly increased relative wall thickness. This measures around 1.1, as well as an increase in thickness of the posterior septum. And one interesting thing we did is we also did a global longitudinal strain analysis of all the walls, as well as the apex here. We see a preserved apical GLS, but a significantly reduced GLS in all the other walls. And this is something, actually a classic feature we'll discuss. So this is the findings that we reviewed. See, here are some of the measurements on the right. We can see that there's severe concentric LVH, there's biatrial dilatation. There is a small cavity and a low stroke volume, spontaneous smoke in the cavity. Interestingly, the patient was quite bradycardic, along with the low stroke volume. Her overall calculated cardiac output is quite low, as you can see on the bottom, of 1.8 liters per minute, and with a cardiac index 1.4 liters per minute per meter squared. There's grade 2 diastolic dysfunction, RV dysfunction. There's a small trace pericardial effusion and an apical sparing GLS pattern. All of this, which is suggestive of amyloidosis. So just to talk about cardiac amyloid, what is cardiac amyloid? It's a form of restrictive cardiomyopathy. These are nice pictures from the ASE poster that they have on this topic. Now, there's two main forms. There's the light chain form as well as the ATTR form. So the light chain form is more of a systemic disease associated with forms of multiple myeloma as well, and it can infiltrate the heart as part of the systemic disease. To note that you cannot actually differentiate the two types based on echo alone, but ATTR itself is more of a disease that primarily affects the heart. And ultimately, they form these abnormal protein deposits in the heart that causes restrictive cardiomyopathy. And some interesting features, you can see a sparkling texture of the myocardium. Many different been described, but you basically see increased echogenicity of the myocardium is what we're looking at. Some of the red flags that we're looking for, especially on initial views, is the reduced mitral PDI velocities. We have reduced GLS with apical sparing pattern. We have severe diastolic dysfunction, at least grade 2 above. It's associated sometimes with the low flow, low grade aortic stenosis. And it's ultimately sometimes a diagnosis that you figure out after you have replaced the aortic valve. So, like I mentioned earlier, AL, ATTR are two different sort of entities that both affect the heart, and the treatment is different. So it's important that to not only look at the echo, other tests. So when you see a finding suggestive of amyloid, the initial step is actually to do a laboratory testing for monoclonal protein, because that is very, very good at ruling out AL amyloid if that's the case. So if the monoclonal protein is negative, which you do with your serum protein electrophoresis, as well as serum light chains and urine light chains as well. When it's positive, you're looking at AL amyloid, and the definitive test is, because it's a systemic disease, you can actually do a biopsy, usually in the abdominal fat pad, to confirm this diagnosis. If it's negative, you're pretty much looking at a possibility of ATTR amyloid. So here, the test that we would do is pyrophosphate, so technetium pyrophosphate scan for ATTR, and it's a 91% sensitive, 92% specific. And usually you have a diagnosis at that point, but if it's still a bit unclear, you can do alternative modalities such as cardiac MRI to give you a bit more clues. And biopsy can be considered, although that's extremely rare, only when you're really not sure of the case. And just some of the other features of AL amyloid I described on the right, to mention that it's a systemic disease and not just looking at the heart itself. And because echo is readily available, this might be one of the first times you actually find features of amyloid first before other systemic manifestations, because some of these things are very common, right? Like carpal tunnel, polyneuropathy. It's extremely common in other diseases. So back to our patient, I think somebody wanted to look at the mitral inflow velocities, which I have actually here on the bottom left here. Assessment of diastolic function is very important when you're suspecting amyloid, just because it's one of the features early on in the disease. Although depending on where you are in the spectrum of the disease, whether you're early versus late, the Doppler profiles can sort of vary. But what you do see is that the tissue Doppler velocities is quite decreased. And when you have a decrease in the E prime velocity of the of the mitral annulus, both on the septal and on the lateral, a decrease of less than 5, as well as S prime less than 5. Here you're thinking of a restrictive pattern that's possibly from amyloid. So that's something to look for. Our patient actually was not that, looking at, this is just the inflow velocity, not the tissue Doppler, but the a low ENA ratio less than 0.8 is suggestive of restrictive hemodynamics. Our patient actually didn't really have that. Anyhow, one of the last things that you should look at that's very important is what we call the apical sparing pattern on the global longitudinal strain study. Our patients actually, GLS actually looked very almost classical for this pattern. And what happens is basically you have this decreased, you have an increased deposition of amyloid fibrils in all the walls, with the exception to the apex, which is actually sometimes spared because it's thin and we have a lot less deposition. And therefore, when we do GLS, we really see this apical sparing pattern. It's affected, but affected a lot less than the other walls. And this sign is actually very, very specific for amyloid. So if you do see this on your studies, really think of amyloid, but it's less sensitive, which is what we would expect. So this is just some of the summary, a slide from the ASE poster and the guidelines on amyloid as well. So looking at the LV wall thickness, myocardial echogenicity, atrial size and function, interatrial septum and valves, as well as the right atrial and PA systolic pressures. We can move on to the last two cases, which will be presented by my colleague, Dr. Al.
Before we go there, and while you're switching, there's a hand with iPhone. So iPhone has a question. You want to unmute and let us know what your question is.
Thank you. It's interesting to note, I thought on the ECG, the patient looked like they were in a sinus rhythm, and there is such a significant degree of stasis within the atria. So I was wondering, because in some people with amyloid, although electrically they have sinus rhythm, mechanically the atrial function may be impaired. So it's a nice case. Thank you, because they can be at increased risk for embolic events, even if they're in sinus rhythm.
Oh, yes. There's guidelines on the management of amyloid, and actually some of the more specific things that are very interesting is that because of the increased stasis, sometimes anticoagulation can be considered just without atrial fibrillation. And also, as you can see in our images, the patient was quite bradycardic. They were put on a beta blocker, and actually, it's a very controversial area where we think that we actually want to avoid beta blockers in these patients because of their very, very small cavities. And the risk you run into, obviously, is that they're compensated by their tachycardia or elevated heart rates. And if you give them a beta blocker, they're at risk of low cardiac output, going to heart failure, shock, and etc. Yeah.
I wonder if Dr. Tasnim is still online and whether she wants to comment on the first case about the rocking of the transcutaneous placed tricuspid valve. No, maybe she's mute. So don't worry. So let's.
I am here.
Oh yes, you want to just comment on the first case?
Yeah.
I was going to ask you.
Sure. So I missed a little bit of the first case, but I think that because I was at the other rounds, so I apologize for that. But I think what I do appreciate, there's significant paravalvular leak, I think, and some rocking of the valve. That can happen both with, with a transcatheter kind of valve placement, but also even with the surgical valve placement. If you have dehiscence of the valve ring, or from a transcatheter perspective, significant regurgitation, you can get that kind of rocking appearance. It sounds like this patient underwent subsequent open surgical replacement. I think if they're a candidate for that, that is sort of the optimal management for those patients. We have seen some patients where there has been a significant leak and some rocking of the valve that have been managed with transcatheter paravalvular leak devices. Yeah, not so different options like Gore device or other things like that as well, that are placed, which can sometimes which can deal with the paravalvular leak. And there has been some success in those situations in patients who are not surgical candidates. Assumedly, they were. If they had a transcatheter valve, it was because they weren't a good candidate for surgery in the first place, and would be even higher risk for this type of a redo plan, like a procedure in this kind of context. So there are some transcatheter options for these kinds of patients, whether the valve was placed transcatheter in the first place or surgically. But ultimately, if they were they were an acceptable candidate for surgery, then that would be the ultimate management option.
Thank you for the comments. So.